Hi everyone, I'm Dr. Roman, and today we're going to talk about iron deficiency anemia. That's right, it's a very important topic. I see this all the time, so I figured I'd make a video on this. Now, before I get started, I want to remind you I am not your doctor. I don't know the specific details of your case, so this is for educational purposes only. I am not providing medical advice. So by the time we're done, you should have a very good basic understanding of what iron deficiency anemia is. How do you diagnose it? What are the symptoms involved? How do you treat it? And how do you follow this condition to make sure that you do not develop iron deficiency anemia again? So with that being said, let's first start off with the symptoms. Now, none of these are really specific to iron deficiency, but in general, they're just specific to anemia per se. And these are the weakness, the fatigue, the pallor, the shortness of breath. Now, I have found that restless leg syndrome and this urge, this craving for chewing ice or drinking very cold water are actually quite frequent in iron deficiency. But again, none of these symptoms are highly specific to iron deficiency. The next thing I want to mention, if you have a history of bleeding, for example, women with their menstrual cycle, especially if you have a very heavy menstrual cycle, what if you have a GI condition where your body does not absorb iron as well, or you're losing iron, especially through bleeding? Some of these are, for example, Crohn's disease or ulcerative colitis or celiac sprue. Maybe you had intestinal surgery, mainly in the small bowel. That's where iron is absorbed. So of course, if you have surgery of your small bowel, you're not going to absorb iron as well. So you got to be very vigilant and think, do you have a condition where either you're wasting iron, mainly in the form of bleeding, or your body is not absorbing iron? Because if you have any one of these conditions and you have symptoms of iron deficiency, or anemia per se, you have to think of iron deficiency anemia as being one of the main causes. Now, the nitty-gritty is in the laboratory studies. So I'm just gonna mention the more important ones that we use. As a hematologist, I order these lab tests all the time. The first one, of course, is your CBC, and you're gonna look at your hemoglobin. If you're anemic, your hemoglobin level will go down. Now, before I get any further, just know that you could have iron deficiency, but not yet developed anemia. That is a possibility. So, and you basically treat it the same, and you actually want to treat it quickly so you do not develop anemia. But usually the main thing I see is anemia, and that prompts a further workup, and we will diagnose the patient as having iron deficiency. The next test, besides the hemoglobin level, is your MCV. That stands for your mean corpuscular volume. This is also part of your CBC. So if you find your CBC, you'll see your hemoglobin, and then a few lines down, you'll find your MCV. And usually the MCV is low, meaning less than 80. Now, this is not specific. I have seen iron deficiency anemia with a normal MCV, but it is usually on the lower side of normal or low. The next test is your platelet count. This is also a part of your CBC. And just know that quite often, if you have pretty severe iron deficiency anemia, your platelet count tends to go up. And when you treat the iron deficiency, your platelet count can normalize. So I don't want you to panic, because I've seen a lot of stress when patients see that their platelet count is high and they also have anemia and they have no clue what's going on. It could simply be a sign or a finding of your iron deficiency. The next test is a total iron binding capacity, also called a TIBC. Not specific, but usually if you're iron deficient, your TIBC will be high, elevated. See it all the time, but it could be normal and you can still be iron deficient. Again, none of these are specific. The other one is your iron saturation. Now, your iron saturation or your SAT, your TSAT, is usually low when you have iron deficiency. And that's actually a pretty good test. But the main test, the one that you should order because it's simple, it's a blood test, and it will virtually confirm that you have iron deficiency, is a ferritin level. Very easy blood test. If your ferritin is low, you have iron deficiency anemia, period. and the magic number tends to be around 30. Now, ferritin is what we call an acute phase reactant. If you have an infection, anything that's causing inflammation in your body, your ferritin level can go up, even if you have iron deficiency. So if you're somebody that has, say, Crohn's disease or ulcerative colitis, an infection, or really bad celiac sprue, whatever the condition that's causing any type of inflammation, if your ferritin is, say, 40, 60, 80, even 100, you could still have iron deficiency. And a lot of times it's kind of like putting a puzzle together. I'll have a patient that their hemoglobin is low. I'll notice maybe their MCV is low, or their total iron binding capacity, the TIBC, is high, or a combination of these. And then I see that their ferritin level is borderline 40, 50, 60, and I see that they have Crohn's, or they recently had an infection, they were on antibiotics. You have to have a high level of suspicion, because that person can still have iron deficiency. And once you treat them, they will get better. The last test, which I really don't recommend doing unless you really have to, is a bone marrow biopsy. Just know that if you have a bone marrow biopsy done and they stain your bone marrow for iron, you can also confirm iron deficiency anemia. But ferritin, less than 30, iron deficiency, period. Now, the treatment, very simple. It's either oral, intramuscular, or intravenous. Let's start off with oral. Any pharmacy has it. I usually recommend 1 to 2 pills a day. I found that giving 3 pills or more is unnecessary, because all you develop is added side effects. I want you to find the usual dose is 325 milligrams. There are different formulations. They have ferrous sulfate, ferrous gluconate, ferrous this, ferrous that. There's many types of iron. The important thing, what I want you to look at, is turn that bottle around. The standard dose is 325 milligrams. But when you turn it around and you look in the section of active ingredients, you're going to find elemental iron. And the average dose, or the ones we recommend, is about 65 milligrams of elemental iron per pill. And I recommend, depending on how severe your iron deficiency is, taking 1 to 2 pills a day. Again, I usually do not recommend 3, because I've noticed that most people don't tolerate it. You can take it with vitamin C. Just know that they say that the vitamin C can increase a little bit of the iron absorption. The side effects. If you think about it, you're taking a pill. Once that pill enters your stomach, the abdominal cramps, the abdominal pain, notice it's very common. The most common side effect is constipation, although occasionally I have a patient that tells me they develop diarrhea. So go figure, it just goes to show you that every single patient is unique, but constipation is the main side effect that I find. Also know that when you take iron pills, your stool may become very dark in color. So I've noticed that adds some level of stress to patients, because when they see the dark colored stools, they may think they're bleeding. And you might be bleeding, but just know that iron does cause this. Now, if you are not improving with oral iron, or you have such severe iron deficiency that you need treatment, you need something that works quickly, or you're not responding to the oral iron, you're having too many side effects, whatever the case may be, then I usually go to either intramuscular iron or intravenous iron. So we'll start off with intramuscular. Very good iron. The main issue with intramuscular iron is, number one, the most feared is an injection reaction. It can be so severe that in rare, very rare cases, it could be life-threatening. You can become hypotensive, tachycardic, short of breath. It's just like a really bad allergic reaction. Luckily, it's very rare, but it can happen. What we try to do to prevent this is we will give you a test dose. We'll give you a small dose just to make sure your body will tolerate it, and we'll monitor you for a while. And if you tolerate it well, then we'll give you the full dose. Also know that the intramuscular iron tends to be a little bit painful, and also it can stain your skin. So it's just things that happen. But again, it's a very good iron. It's very quick, except for the test dose initially. And once you get it, I've noticed that if you tolerate it, we can give you multiple doses, and most patients tolerate it very well. Unlike oral iron that takes time to work, okay, well, you'll start oral iron and it takes weeks for you, usually it'll take weeks for you to start noticing an improvement, the intramuscular and the intravenous iron tend to work much more quickly. Now, the intravenous iron, the unique thing is you do not get the GI side effects. Just like the intramuscular iron, it's given to you in a shot, and the intravenous is in the vein, so you do not develop the constipation, the diarrhea, or better said, usually you do not develop these. The abdominal pain, the cramping, the diarrhea, or the constipation, which is the main one. It's very quick. Unlike the intramuscular iron, you do not need to give a test dose for most intravenous irons. Although some people do, but just know for most of them, it is not absolutely necessary. IV iron and intramuscular iron work very well. Unlike the intramuscular iron, this one does not hurt. Usually it doesn't hurt. It does not stain your skin, although it can if they don't canalize your vein properly. It can happen. But for the most part, very good iron, works very well. I usually give about 4 to 6 doses of intravenous iron or intramuscular iron, usually separated about a week apart. So they'll come into my office, sometimes twice a week if they have very severe iron deficiency, but I've noticed that most patients prefer coming in once a week, and like that, they don't lose a lot of time either in school or work or what have you. Now, that's pretty much it for treatment. I do want to mention there are times that I give a person therapy, whether oral, it happens more with oral, but it could be oral, intramuscular, intravenous, and their hemoglobin will improve, their iron level will improve, mainly their ferritin level will improve, but they don't normalize. And the main reason for this is you have not addressed what caused the anemia to begin with. And I'll give you some examples. If you're premenopausal, and you're still bleeding, you're still having your menstrual cycle, remember, I'll give you iron. You may even get it in the vein or intramuscular. But if you're still bleeding from that menstrual cycle, every time you have your menses, your hemoglobin level and your iron go down. And I see this all the time. And once a woman hits menopause, a lot of times, boom, their iron deficiency anemia disappears. And of course, that's it. Their menstrual cycle is gone. The same thing with a person, as I already mentioned, who has Crohn's disease or ulcerative colitis. If you're chronically bleeding, little by little, that trickle, your iron levels will go down. And if you're bleeding a lot, if you see the blood in the stool, then your iron level and your hemoglobin level will drop even sooner or quicker. So you got to have a lot of clinical judgment when it comes to this, because I've noticed patients that get frustrated because they tell me, I'm getting all this iron to no avail, I'm still anemic. And I tell them, yes, but if you're bleeding or if you're not absorbing iron and your hemoglobin level is going down and your iron is going down and you do not get iron replacement, guess what? You will end up with a blood transfusion. And that's what we want to avoid. That's the number one reason I want to avoid. And the other thing I want to make sure is that you are having quality of life. If you have low iron levels, you are not going to feel well. You're going to have the weakness, the fatigue, all the symptoms I've mentioned, lack of concentration, no desire to do your activities of daily living. I mean, people get depressed. I've seen, especially young women with a heavy menstrual cycle, where they get depressed. And that's something that's quite sad, because overall, we do have treatment out there. Even if you don't tolerate oral iron, we'll give it to you intravenously. We'll give it to you intramuscular doses. And, that tends to take care of the problem. Now, for follow-up, it's very easy. We'll follow your blood tests. I tend to follow your CBC. I want to make sure your hemoglobin normalizes. Your MCV goes up if it was low to begin with. I want to make sure your TIBC comes down. And most importantly, I want your ferritin level to normalize. I'm usually content if it's above 50. My go-to number is about 100. That's where I would like to see your ferritin. Now, if you're a young woman who's menstruating, or you're a person that has Crohn's disease or celiac sprue or whatever the case may be, if I can have your ferritin higher than 100, I will be happier. Because you know what? It's going to take that much longer for you to end up back in my office. I don't want you to have to see me. I want you to be home enjoying the things that you enjoy doing and not be stuck in the doctor's office. So always remember, if you're postmenopausal, this is the last point, very important, one of the most important points I'm going to give you today. If you are iron deficient and you are postmenopausal, or you are a man, always think of the possibility of an occult GI malignancy like colon cancer and ask yourself, am I due for a colonoscopy? As a matter of fact, even if you're young and you have severe iron deficiency, I always consider sending the patient to the gastroenterologist just to make sure there is no colon cancer or cancer anywhere in their GI tract. It's very rare. I don't want you to panic, but just know that every once in a blue moon, I will find a cancer, especially colon cancer, in a patient who presented with iron deficiency anemia. So that's it. I hope this helps you out. If you find this educational, if you like this content, consider subscribing. If you have a question that I have not answered in this video, consider leaving a comment below and I will do my best to get it answered for you. So thank you, and I will catch you on the next video.